Yes, we can see it. Yeah.
Okay. So I'll just introduce myself quickly. I hope this goes a little better than my lovely performance over there. So my name is Mackenzie Fowler. I am a postdoc in hematology and oncology at the University of Alabama at Birmingham, or UAB. Let's see, I am funded by a T32 that is supported by the AHRQ. This particular T32 is focused on outcomes research, translational research, and health disparities research. So my research is focused on the overlap between cancer and aging, particularly related to cognition and the development of dementia. I am an epidemiologist. I got my PhD from UAB in epidemiology last year, been almost exactly a year. So without further ado, I don't think I have to tell anyone in this room or in this audience that the United States population is aging. And as a result, the incidence and prevalence of aging-related diseases such as cancer and dementia are also increasing. In addition, cancer and dementia actually share several risk factors, most importantly, age, in addition to diabetes, physical activity, among others. Cancer and dementia also share cognitive consequences. And for those who don't know, the cancer-related cognitive impairment is typically as a result of the cancer itself or the treatments. It can be present even before treatment, and it persists long-term. So longitudinal studies of the association between cancer and dementia actually suggest that patients with versus without cancer history have higher cognitive scores at their dementia diagnosis, but that they decline similarly over time. Racial disparities also exist in cancer and in dementia individually, but few studies have examined racial disparities in the relationship between cancer and dementia. So the goal of this study was to evaluate racial disparities in that association. So we included individuals with all-cause dementia from the electronic health record at UAB, and we retrospectively collected whether the patients had an exposure of non-central nervous system cancer prior to dementia diagnosis, and that was determined by ICD diagnosis codes. We evaluated their cognition over time using the Alabama Brief Cognitive Screener, or ABCs. This is a measure that was developed by David Geldmacher, who is the head of our memory disorders clinic at UAB. He's been in the dementia field or the Alzheimer's disease field for a while. Basically, it is an instrument that we're able to implement into our EMR for serial cognitive testing over time. So it's very similar to the MMSE, and the scores also range from 0 to 30, with higher scores indicating better cognition. So statistically, we use linear mixed effects models to evaluate the role of cancer history on cognition in dementia over time, and then examine interaction by race. So overall, our sample had about 3,809 participants. 672 had cancer history. About 20% of our sample self-reported as Black, and about 20% of the cancer-exposed participants were also Black. After adjustment for demographics, socioeconomics, and comorbidities, and then some medication-related factors such as anticholinergic burden and whether these participants were taking a dementia-related medication, we found that overall, those with cancer history had higher mean cognitive scores at dementia diagnosis, but that, similar to the other studies, they progressed very similar to those without cancer history. Did not show that data in this presentation. After stratification, though, you can see that whites with cancer history, they begin higher at dementia diagnosis, and then they look like they progress just a little bit slower. That slope is, neither of these are statistically significant, but they're borderline, and that slope is just a little bit slower for those with cancer history. But then when you compare it to the Blacks, you can see that overall, whether they had cancer history or not, whites were better off, period. Throughout the entire period of follow-up at baseline, they started higher. And then also you can see that among the Blacks, that association with the cancer completely disappears. So we hypothesized several potential causes. And the main thing, the overarching thing, is access to care. We've talked a lot about this throughout these past couple of days, and I think mine just kind of adds to that. So first, in dementia, Blacks are known to already be captured later in the dementia disease process. This may be further compounded for people with cancer history. Maybe they assume, or their providers assume, that their cognitive impairment is a function of their cancer or their prior cancer treatment, and just don't send them for further evaluation. Secondly, they may have lower cognitive reserve. So maybe if they are already, less educated, or they have lower cognitive reserve anyway, they develop cancer that overwhelms what cognitive reserve they have. And then when they later develop dementia, they do start more similar to their non-cancer counterparts. On the cancer side of things, Blacks may have differing survivorship follow-ups. So survivorship guidelines for cancer indicate that primary care should assess for late and long-term effects, such as cognitive impairment. These guidelines may not be being followed as well in Blacks. National Comprehensive Cancer Network guidelines for cancer treatment are not followed as well in Blacks. So it stands to reason that the survivorship guidelines may not be followed as well either. There also may be a differential survival bias among Blacks compared to whites. So overall, additional studies are needed, especially to examine by cancer type, as those are very different, and by cancer stage. And of course, to examine the role of specific cancer treatments, especially as more immunotherapies and things like that come online. Qualitative and quantitative studies of the impact of social determinants of health on dementia patients with and without cancer history should also be a research priority. I wanted to note quickly that these interactions are three-way interactions with time, cancer, and dementia. And so, or time, cancer, and race, I apologize. So interpretation is a little difficult. And in addition, I still want to emphasize the role of cancer treatments, particularly if we see that cancer treatments provide some modification of this effect. It could provide some insight into some targets for dementia therapeutics, or as somebody alluded to earlier, drug repurposing. And I'm not advocating giving chemotherapy to dementia patients, but thinking about some other things that come online with cancer treatments. Finally, I'd just like to acknowledge my collaborators. This is my dissertation committee. This is part of my dissertation work. It just got the revise and resubmit from Journal of Alzheimer's Disease, so it'll hopefully be coming out in the next couple of months. But thanks for letting me talk.
Thank you, Mackenzie. That's a great talk. Do we have some questions? Okay, probably I will ask question if you don't mind, Mackenzie.
Yeah, go ahead.
I still cannot see you because I still can see your shared screen, so I'm not sure where you are, but okay. So my question is about, we talked about gender specific, okay, thank you. Gender specific disparities. Did you have chance to look at the same associations, but specifically for males and females, and together race and gender specific associations?
That is not something that I've looked at. That's an excellent point. That is something that we should look at for sure. A lot of the literature, especially related to cancer-related cognitive impairment, is in breast cancer, so mostly in women. Particularly the fact that breast cancer also has a lot longer survivorship period. We may see differential effects for women with breast cancer, and then of course women more likely to get dementia later. So that is well taken, and I will definitely look at that.
Yeah, and actually my second question is just about the topic you just started to talk about, cancer types, because right now you had, like cancer in general. I understand that probably it's not so many cases in this cohort, but what do you think in future? Because that will be very interesting, because cancer type could also impact the associations with dementia and Alzheimer's disease. Do you think you will be able to look at certain cancer types specifically for these associations?
So I am hopeful for that. A lot of my problem to date has been data and lack thereof. So the dementia studies that have good cognitive data don't have good cancer data. And then vice versa, if they have great cancer data, they don't have good cognitive data. So hopefully as I, write a K award and everything, I can kind of tack on to some of our survivorship studies that are going on and add a cognitive piece to that, and hopefully look at that, by cancer type specifically, because yes, the cancer type drives the treatment. Of course, with things like breast and prostate cancer, you have the hormonal element as well. So definitely some important things to look at. I'm very hopeful that we will be able to get there in the next few years.
Okay, great. Thank you very much for your response. Do we have some other questions to Mackenzie?
Yes, I have a question. You know me, so I won't introduce myself. So you acknowledge the fact that Black older adults are diagnosed later in the disease process for dementia and Alzheimer's. But do you also acknowledge that there Black people in general are diagnosed later in the later stages of cancer, and wondering what the impact of that would be on dementia and Alzheimer's? That's one question. And while you're there, can you think of why the guidelines are not followed with Black people?
Yeah, so I'll speak to the first question first. So yes, they typically are diagnosed at later stages of cancer, and that's kind of what I tried to touch on with the survivor bias. Certainly, African-American patients may definitely die from their cancer way before they develop dementia. And that's something that we are going to have to take into account and look at. At UAB, I'm hopeful that that wasn't the case. We serve a pretty diverse community, and we are the site of the only comprehensive cancer center in 4 states. So I'm hoping that people do get cancer care pretty well at our facility, but certainly looking at larger databases and larger studies that have been done on this. Yeah, that is an excellent point, and definitely something we need to somehow figure out how to account for. The second question, as far as why they are not receiving NCCN guideline care, I think some of it is, again, back to the access to care issues. Something I'm kind of passionate about is rural-urban disparities. I think some of that is related to, just not having access to like a comprehensive cancer center. And so maybe some of these rural cancer clinics don't follow NCCN guideline care well anyway. And then, of course, the whole disparity with African Americans anyway. So I think some of that is relevant there as well. It's certainly something that we do need to tease out a little bit further, though. Thanks.
Okay, some more questions?
One more.
Okay.
Less a question, more an observation.
Yeah.
The 4-state area you serve, that's a fantastic opportunity to look at health outcomes.
Yes.
Because Alabama in and of itself has its own issues. And what states are you serving?
We serve Mississippi, Tennessee, Alabama, and Louisiana.
Okay, so you got the trifecta of
Yes.
death. It would be fascinating. I don't know if you have the time or your colleagues, and you may already do it, but just to see, what the movement is. They come, they get great care from you, and then they have to go back to, Bayou Lafourche or something in Louisiana, and things go bad.
Absolutely. We serve patients. I mean, even we have patients from New York that even come down and then go back home.
It's a fantastic service, but it's also a great opportunity to look at health outcomes.
And I will say that we've got a great outreach group, and we actually have a study that is going into some very rural counties in Alabama, Dallas and Hale County, taking like a truck, and they're looking at cardiovascular outcomes, but they are taking a physical truck and collecting, scans and biometric data and all kinds of stuff from these people, which I think is awesome. And I think it's a good framework for dementia research and beyond. So,
because there's probably 3 geriatricians in the whole 4-state area. And,
pretty much,
So everybody does what they can, but understanding, how differences like that affect outcomes is fascinating to me. So thank you. That was great.
More questions? Okay, thank you.
Mackenzie, I would think that SEER Medicare data would be very helpful for your study. Do you plan to get this data and compare somehow to
Yes.
what you receive?
So I am looking at I'm trying to get SEER Medicare data, I should say. I'm trying to get that. It's a little expensive, so having the funding to do that is difficult at my stage in my career. But I am actually I'm going to use that data to look at incidence and prevalence of dementia among colorectal cancer survivors. I would like to do more cancers, but I don't have the funding for that yet. That's about $5,000 just to get the colorectal cancer and the non-cancer cases to compare. They don't have great cognitive data though, because it is Medicare, and SEER does not collect cognitive data. So that's kind of the drawback to being able to use that as far as looking at the cognition. But looking at the incidence over time may be helpful, and even using maybe the MDS, we could get some level of information. But
I know in some states, the SEER coverage is pretty spotty.
it is. So SEER does not cover every area, but it is designed to be relatively nationally representative. They have SEER registries in Georgia, and then across the US. So it's not going to be a perfect estimate, but it will be better than just extrapolating. Right. Right.
Importantly, that we can have both Medicare records and cause of death for the same individuals.
Yes.
Okay, Mackenzie, thank you for initiative, for your poster. And let's. So we need to discuss what we wanted to discuss during our session. I would suggest to start from your, Julia, conclusions. Could you summarize again the directions you suggested for research, and maybe we should think what is feasible for our group, and where to research new discoveries and something like this.
Okay, so I think that actually, of course, I could summarize these directions, but you know, as I mentioned, that was just part of the issue of disparities in Alzheimer's disease. So predominantly what I described was predominantly related to analysis of large data, large clinical data, and population-based data. And actually, that sort of summarized many presentations of other presenters, that we need information on all ages, including oldest, old patients, to be sure that we cover the spectrum of patients aged like 80 and older. Of course, definitely, we need to move forward with resolving the issue of underdiagnosed Alzheimer's disease, and how we can get this information in already existing data sets. Of course, we need to think about engagement in studies, patients of different race and ethnicity, and to think about gender-specific analysis. And we need to look at comorbidities not as one disease, but not one disease, sorry, number of disease, but instead of specific diseases named by each disease, because they're so different in terms of race-specific risks and gender-specific risks. We also need to include other factors like social factors on individual level and area-based level, and environment exposures, if we can obtain them from environment data sets and to link it to the data to health data. And actually, as we can see, it will look like very large construct. So we need to account simultaneously for many, many, many factors. We should understand that these many factors interrelated with each other and often depend from each other. And that's mean the task, at least I believe now, is how to develop methodology that would be able to make next step to real life studies when we could include multiple factors or group of the factors simultaneously into analysis because every patient has multiple, like 20, 30 probably different characteristics from demographic, social economic, environment, exposures, comorbidities, and so on, so on. And that's actually a lot of work with the specialists in methodologies, how we could account for these multiple factors, how we could get this closer to real life analysis. And then we expect that if we can move through this methodological issue, then we could start getting the result that could be ready for evaluation of interventions. Because if we will make intervention in 1 or 2 or 3 or 4 domains simultaneously, so we could better predict it if we already have such models. So probably you would like, from methodological point of view, discuss how can we move forward with such approach to multi-scale analysis, multi-dimensional analysis.
Very good question. And I would say that very general answer, this is like a title of our workshop. We have to leverage modern analytical methods to existing data and try to extract what you mentioned. Yeah. Okay, let's discuss in some. Look, we had a poll. We had a poll survey today, and asked participants about their beliefs on what is more important factor contributing to different Alzheimer's disease and related dementia disparities. And winner is socioeconomic factors. But look, directly, social economic factors can't generate Alzheimer's disease. We should think about intermediate mechanisms, how social economic factors works to generate the risk, increase the risk of Alzheimer's disease, and simultaneously different risk between different subgroups, and therefore to generate health disparities. Does anybody have an idea how actually socioeconomic factors works to generate disparities? And you just told me that probably socioeconomic factors much more important. Carl, you would like to say something?
Yeah.
You have this one. Okay.
Yeah, so, you know, my focus has been on studying the genetics of Alzheimer's, and even with that being my focus, I do come down to the disparities really is driven by differences that we see in socioeconomic, social, environmental differences between populations. And I think some of that may be the differences in comorbidities that drive it, systemic racism, problems that we have in our country from historical, historical reasons like redlining and all that, creating situations where we have this, you know, a kind of over your lifetime, these factors build into your risk of Alzheimer's, right? So I think that's where, to me, the genetics is not really going to be where we see driving the disparities. What I do see with the genetics, and I think is important with the genetics, is we do see differences among populations in genetics. And we're seeing in our studies that some of the risk factors are going to be different based on your ancestry. And if we're not collecting enough genetic data on all different, you know, ancestral backgrounds, we're not going to have the data to look at, you know, in terms of drug development, making sure it works on all populations, and also precision medicine for like prediction of disease. If we don't have the data to construct polygenic risk scores that are more precise in every, you know, group, that's where I think we can end up driving more disparities again. So I think that's the importance of genetics
maybe some factors like access to care,
yes,
maybe different level of modern treatment between subgroups could
for sure, yeah,
play a role.
Yeah, I was just going to say resources like access to care, you know, are important, right? But it's the structural racism over time that has denied the equal distribution of these resources, some of which, again, remember the education and heart disease chart. As education increased, the black-white ratio got larger, right? So,
exactly.
So there's something around social mobility, gaining these, attempts to gain these resources that can be stressful for some of these groups, and people in these communities, populations cope, you know, in unhealthy ways that may be threaten their cardiovascular health and dementia risk over the life course, right? So yes, it's SES, but race, but discrimination in this country, I think, is important it's the fundamental factor for why people don't have equal access to important health protecting resources.
Okay, may I just have a comment? What do you think about social construct studies versus only race-specific analysis? Because now, for example, we have increasing number of publications that describes that social construct, it's mean like environment, including all social economic factors and cultural factors and behavioral risk and so on, is probably more important even than for many diseases than dividing per race or ethnicity, which means genetic background. So what I would like to ask audience about what they think about social construct idea and its perspectives in Alzheimer's disease.
Well, maybe not directly, but I was going to follow up what Carl said. I'm sorry, Brian, before we get too far away. So the nature of the question sort of puts us into a false dichotomy, right? Is it health? Is it socioeconomics? Is it genetics? Well, the question's wrong, right? All of these things are very closely related. So think about this, right? We have two neighborhoods, right? And two identical people, maybe they differ by race, but otherwise two identical people growing up in two neighborhoods. In one neighborhood, we have a Publix nearby, a Wegmans if you're from up north, right? So we have some nice stores nearby, right? There's some nice parks nearby. You can go outside, right? The train doesn't go in the middle of the night, right? In another neighborhood, we have a 7-Eleven and an ABC, right? Given to identical people as they're growing up, one is going to be much more likely to get diabetes, much more likely to be exposed to stress, much more likely to have lower cognitive effect, much more likely over the course of his or her life to develop the diseases which will lead to the development of Alzheimer's disease. But it's all tied together. We can't just say, oh, we're going to grab some socioeconomics, right? Oh, we're going to concentrate on behavior, right? It all comes as a lump sum. Now, your genetics may even modify that. You can't do anything about your genetics, but the key is it's all together. And when we force ourselves into these questions, what's more important? Well, it doesn't matter what's more important. In order to design an intervention that actually works, right? It could be, I'm just saying this, the APO4 gene is the most important thing. Can't do anything about it, right? Can't do anything about it. So if instead we concentrate on the problem as a whole, right? What's causing our comorbidities, right? What's going on in midlife? What's going on in early life? Maybe we'll have a much better chance at figuring out why different people at 85 and 95, provided they get to live that long, not everyone makes it to Alzheimer's disease age, why the differences exist.
Great. It's a very great discussion. First of all, I mean, just looking at the title of this overall workshop, leveraging existing data and analytical methods, I'm amazed at the amount of each talk presenting different perspective and the amount of data, how we can consolidate and bring us all together thinking alike. So that's just a comment. Back to the discussion which was taking place. Look, what you just said may be very true. There are two factors, genetics and epigenetics. And SEC, socioeconomic conditions, do relate over decades and centuries to start having effects. And unfortunately, as Carl said, in this country where there is clear disparity, we cannot deny that. And with poor socioeconomic conditions comes all some of the high risk factors that we have been talking about. High cardiac condition we talked about, high obesity we talked about. Actually, Carl early in his talk mentioned even there is a climate effect, pollution. We don't know who has studied pollution closely. Now, genetics and epigenetics works together. Maybe that's why we are seeing those effects and needs to be studied more closely and try to understand that. We will never be able to overcome this. In the next just decade, it will take ages before we can dilute the effects, but we need to start somewhere. By acknowledging that these are the factors. B, then trying to address that. And it's good to see that we have at least started acknowledging that. And thanks to NIA and AIC, that we are paying attention to some of these facts.
We have a raised hand from our audience. Could you please?
So I've been just advised, with your permission, that there are some hands up from the Zoom, and that's. Can you remove that?
Yes, I think Dr. Abanish Singh raised a hand.
Okay. Why don't we ask him to? Anna actually had her hands up. Can we ask Anna to make a comment, please?
But one second. So the panelists that raised a hand need to be unmuted. Yes, Dr. Abanish, you can go ahead.
Thank you. So this is Avneesh Singh, and I serve on the Faculty of Behavioral Medicine and Neurosciences here in Duke University School of Medicine. Concerning the topic about how socioeconomic status may affect AD, I have just a small comment. Several experts, including Dr. Carhill, have mentioned that most of disparity may be contributed not from genetics, but from social, educational, and economic factors. However, it is also a matter of fact that without involving genes or genetics, the social, educational, and economic factors themselves may not be able to cause physiologic changes in the brain resulting AD. So what might be happening, to the best of my opinion, and I have seen some of these things in my work earlier on cardiovascular disease, these factors may work along with genetics. And when I talk about genetics, I'm not talking about just genetic variations. I'm talking about genes, the expression of genes, the end product that we get from genes, the proteins. And these factors may interact through regulation, through epigenetics, rightly mentioned just a minute before, through methylations, maybe from that pathway, socioeconomic status or educational status may actually affect genes that are responsible to create or for the development and the progression of Alzheimer's disease. So far, the focus has been only on genetic variations, which is okay. But I think at this point of time, we do need to take a leap from here and look for epigenetics as well. Thank you.
Thank you. And I would like to make a comment that we have in our chat the link from Catherine Gary about the paper. So she suggested to look at this paper. So we would definitely share this information with our audience. If Catherine is here, probably she would like to make comment on this paper.
So can we?
Yes.
Just a minute. So we will provide opportunity.
Okay, thank you.
Catherine Gary, yeah, you can go ahead and talk.
All right, can you guys hear me?
Yes, that's great.
Yeah, just kind of what one of you guys suggested about like race and SES kind of interacting with each other. There's a really good paper by Lincoln Phelan that just reminded me of. And they argue that SES and race are fundamental causes of illness, meaning that they're the ultimate risk factor that put you at risk for other risk factors. So for instance, maybe you're obese and that is making you more susceptible to certain illnesses, but like, what if you can't afford anything other than McDonald's because you're poor? And I just thought, like, based on what you guys were saying, that this paper could be very helpful theoretically when framing a lot of these concepts.
Okay, thank you. Thank you, Catherine. And we have raised hand. I can see Yuri Loika. So you would like to comment, please?
Yeah, thank you very much for allowing me to provide a comment. I would like to emphasize that in this meeting, researchers from different areas presented their results. It's epidemiology, demography, as well as biosciences and in drug development. And therefore, it seems that each of these discipline is in each discipline, different levels of problem are investigated. And in my opinion, what is missing is a link between different levels that were observed in Alzheimer's disease. Let me provide a few examples. For instance, preparing homework at school. Okay, it's affect the brain development, but at the same time, it can result in different level of stress in different group of people, depending on how they perceive the homework. And therefore, having the same level of education, final level of education, it would be a different effect on the stress on the brain development and probably on the development of Alzheimer's disease as well. The other one is, for instance, at the same time, if the perception of homework is the same in different groups, but there is a different access to food or to the quality of food. Okay, the people access different food with different quality, and therefore it could result also in different neuronal development in the brain. Therefore, it also will result in different development of progression of Alzheimer's disease. And therefore, in my opinion, what could be done is to establish a link between the higher level, which is on the investigated in epidemiology, demography, and to provide and to find links to biological processes that underline the difference between different ethnical group and so on, and finally to develop either drug targeting the high level or development interventions that will be supported by biological processes involved in the Alzheimer's disease. If both of them will be combined, probably it would be the best that we can do now or in the future. Yeah, thank you.
Okay, thank you for this
Yuri.
comment.
Let me announce the last pool survey. We had two, and the last one. Please participate in our survey. This is 1 minute, and then we will continue. Please.
Anatoly has raised hand.
Okay, then
let me feel.
Mm-hmm.
Okay, can we continue? Anatoly?
Okay. I'm very glad that Abanish and Yuri addressed the question about stress. I think that's one of the big issue in case of Alzheimer's disease and many other aging-related disorders. In case of Alzheimer's disease, the evidence is accumulating that stress really makes a huge contribution to development of neurodegenerative disorders, including Alzheimer's disease. People distinguish between at least two kinds of stress, external and internal. The internal stress related to, let's say, genetically inherited mutations, or maybe acquired mutations, somatic mutations. And external stress, one example could be psychosocial stress, which people experience during their life course. Important question is how this external stress let's say, get under the skin. And that's a big problem which many people try to address. But the point is that it goes through genetic expressions, and it's coming from sensors of this external stress in our brain, and it's coming to cellular stress, which generate all kinds of processes, and what people actually try to understand, making genetic analysis, gene expression analysis, and so on. The important point is that people experiencing the same kind of stress have different, sometimes dramatically different stress response. And prolonged, let's say, stress response is a source of so-called allostatic adaptation, allostatic load, which increase the risk of mortality and different kinds of diseases, including Alzheimer disease. So allostatic adaptation is just the expression of different kinds of biomarkers, which change homeostatic regulation in the body and just move it in the direction of more higher risk to different kinds of exposures. It turns out that our previous experience, we have two people with different socioeconomical status. These people during their life have different experience of communication with environment. Those people, those person who has higher socioeconomic status, thinks that he has maybe more friendly environment compared to those person who don't have similar level of socioeconomic status. It means that they have different experience. And it turns out that our brain has emotional memory. This memory is written in neurons in the part of the brain called amygdala. So each time when person experiences stressful event, it's automatically projected this new event to past experience. And the decision is whether his stress response will be like panic attack or just the person who says, no, nothing at all. It's not a problem. Let's wait and everything will disappear. So these different attitudes could be the source of very serious illnesses. In particular, when human resources are diminishing with increasing age, people became more and more vulnerable to stressful conditions. The same stressful conditions which would be tolerable in young ages, and it was no problem at all. So it means that one of the reasons for disparity is in historical exposure of people starting from the very beginning of life to different conditions. And if this experience is bad, then person has high chances to develop different kinds of health disorders, including Alzheimer. So that's social and sometimes political problem. We should understand that it's not easy, even if we find some scientific solution. It could be socially or politically difficult to make, let's say, to make this kind of reality, which could support this conclusion. But that's what we should understand, and it could never done fast. So any kind of social, economical transformations take time. But researchers should understand what is the right way of doing this. And understanding how stress penetrate under the skin is one of the way to address this issue. Of course, this is epigenetics and also some genetic predisposition as well. But that's how it should work, I think. Thank you.
Anatoly, does it mean that this is your version of answer on the question how CES generate disparities? Not
Absolutely.
through
Yes.
care, but through higher stress exposure.
Yeah, it depends on the perception of stress. And the point is that sometimes not the stress itself, but the response to it. But the strength of response depends on perception, personal perception, which depends on personal experience. If let's say, that's like traumatic brain disorder after for people who experience some bad situations during the war or in some other places. So there is some memory in our brain which produce undesirable stress response long enough to create problems for risk of developing different kinds of disorders.
Okay, thank you. Thank you very much, Anatoly. So probably I would like to ask the question because we have just 1 minute before our next presentation. That's a question to specialists in analysis and methodology. How long you think it will take in months or years to develop an approach that will simultaneously be able to accommodate all this multi-scale, multi-level analysis that we discussed just during these 2 days and create a more comprehensive, closer to real life model of Alzheimer's disease risk of incidence, progression, and survival of Alzheimer's disease patient. How long do you think it will take, and what we need right now, what we do not have yet, but what we need that will move faster to achieve this purpose?
I can give you a practical answer. I live in a world of funding percentages. Until we educate study section to invest in studying small population research, underserved populations, and high-risk studies, we're not going to make any progress whatsoever. We cannot get these studies through. I sit on study section and I see wonderful studies, small samples, good design, but it gets shot down. Until study section at NIH starts to invest in small population research, we're not going to go anywhere. If I was writing a grant for small population research, I'd go to Alzheimer's, I'd go to Robert Wood Johnson, I would go to Templeton. I would not go to NIH because your chances of getting funded are very, very small. It's our problem. We do this to ourselves. We want to research, we want to support the big flashy studies that generally consist of a high proportion of white populations. And then we have to oversample smaller populations, which is unsatisfying at almost every methodological I can think of. So that's just a practical issue. If study section invests, we will get these numbers. We will be able to succeed. We know what the problems are. We know how to measure them. What we don't have is the resources to do it effectively for underserved populations.
Okay, thank you very much for your comment. And I think it's 4:32, and what Dr. Kushevich think, should we start with case presentation?
Yeah, I just wanted to follow up, thanks, on some of the talks about epigenetics, and this follows up with what I think you're asking, what do we need? In terms of trying to understand what is driving the disparities and how epigenetics and genetics kind of tie into that gene-environment interaction, there is a disparity, a lack of data actually in underserved populations in epigenetic. I talked a lot about the genetic data, how we have a disparity in what we collect there, and we're trying. As Damali pointed out, the NIA is working on correcting that, but there is also a lack of functional data from expression studies and also epigenetic studies that also needs to be really collected in these populations to understand the disparities better and what may drive them in terms of social along, and of course they also have these data sets need to have the social factors as well, so we can see how they interact, right? So it is a big challenge, but I think that's really would help us answer a lot of questions.
This is where we go in. We need to go. Yes, thank you. So time is over for our round table. Yeah. Do you, Julia, think that we can go to the next item?
we didn't get clear, conclusions from our roundtable, but probably it's not so bad because we still could communicate even after this workshop, and we can think about new collaborations and developing these new approaches. So it's good to exchange the opinions. And I'm